Vinformax presents Medical Procedure: Intraosseous Needle Insertion in Adults. Overview: Obtaining venous access in critically ill children as well as in adults is an essential procedure to restore blood volume and to administer drugs during pediatric and other emergencies. The first option for vascular access is through a peripheral vein puncture. If this route cannot be used, or if a prolonged period of access is necessary, then the intraosseous route is an effective option for rapid and safe venous access. This video describes the placement of an intraosseous needle in adult patients by manual insertion using the mechanical device. Anatomy: The medullary cavity is the highly vascular structure that functions as a non-collapsible vein. This is capable of accepting a large volume of fluid and medications and rapidly delivering them to the central circulation. The medullary venous sinusoids drain into a central venous channel that exits in the bone in the form of emissary and nutrient veins. The rate of infusion is restricted by the size of the medullary cavity and also by the diameter of the intraosseous needle. Site selection: A number of sites can be used for intraosseous needle insertion in adult, such as the proximal tibia, the distal tibia, the distal femur, the calcaneus, the sternum, the humerus, and the styloid process of the radius. Out of many sites, one of the most preferred sites is the proximal aspect of medial surface of the tibia. Now, to locate the proximal aspect of medial surface of the tibia, first trace the tibian tuberosity. After tracing the tibian tubercle, 1 centimeter below the tibian tuberosity is the preferred site for the intraosseous access. Preparation for manual insertion: The following things are assembled in preparation for the intraosseous insertion: sterile towels, a 10 cc syringe for aspiration and infiltration, 1% solution of lidocaine for analgesia, infusion kit, intraosseous needle, lidocaine, iodine solution, micropore tape, gauze pack. Inserting intraosseous needle manually. Accessing the intraosseous cavity is an emergency procedure. Hence, it is rarely possible to obtain informed consent before performing the procedure. If possible, explain the risks and benefits of the procedure to the patient or the next kin. Otherwise, proceed with the insertion. The procedure starts with the positioning of the leg with the hold towel so there is slight flexion at mean and external rotation at the level of the hip. Now sterilize the area with iodine solution and drape it. If the patient is conscious, then initially you will have to anesthetize the local area by 1% lidocaine. Stabilize the leg with the non-dominant hand. Hold the needle in the palm of the dominant hand and position it at the 90-degree angle to the long axis of the bone. Advance the needle through the bone cortex with a rotary motion with a steady pressure. A great deal of resistance is encountered. A sudden loss of resistance indicates that the needle has penetrated the cortex and has reached the medullary cavity. Now remove the stylet and connect 10 cc syringe to the needle. Aspirate for blood or marrow contents or both to confirm correct placement. Make sure that the fluid flows easily with no resistance. If the fluid does not flow easily, reposition the needle by pulling back slightly. But If the resistance is encountered, the needle should be removed and a new site has to be selected. Secure the needle with the bulky gauze dressing and micropore tape. Infusions. The following can be administered through the intraosseous route: crystalloids, colloids, blood infusions, resuscitation drugs, vasopressor. In addition, the sample can be drawn from the intraosseous space in the critically ill patients. Contraindications. The contraindications include ipsilateral fractures, local vascular injuries, cellulitis, burns, also previous attempts of ipsilateral intraosseous access. Complications. The most common complication of the intraosseous needle insertion is fluid extravasation resulting from through and through penetration of the bone, or maybe from the incomplete insertion of the needle. In the case when an extravasation occurs, the needle should be removed and pressure has to be applied on the site. Compartment syndrome is infrequent, but could be possible if the needle is placed incorrectly. Bone spicules may cause blockage of the needle. To prevent blockage, the line should be flashed 3 or 5 cc of saline every 15 minutes. The other complication includes fracture, infection, fat embolism, local hematoma, pain, local inflammation of the bone at the insertion site, and necrosis of the skin at the insertion site. Summary. Intraosseous needle insertion is used as a temporary measure when intravascular access is not achieved through peripheral or central venous routes. The intraosseous needle may remain inserted for 72 to 92 hours. It is ideally removed within 6 to 12 hours as soon as an alternative intravascular access has been established.